Okay, so you all had a PLA on clinical heart conditions or clinical heart diseases, something like that. And you had a PLA, or not PLA, a case study last week. The answer was congestive heart failure. Now, with that one, that patient was actually exhibiting symptoms of both-sided, but congestive heart failure affecting both sides. Like we mentioned during the quiz, if you have a left-sided heart failure, you're going to end up having a pulmonary congestion because it backs up to the lungs where it came from. And so you get things like orthopnea, which we talked about with pericarditis and pericardial effusion. When you have orthopnea, that means you're having trouble breathing while you're laying down because of the congestion in your lungs. So they were experiencing pulmonary congestion and orthopnea. Right-sided congestive heart failure affects the systemic circulation. It backs up to where it came from, which is going to be displayed most in your extremities. So you end up getting congestion of peripheral tissues, which would include liver congestion and GI congestion, but as well as congestion in the peripheries in your extremities. So you get swollen hands, swollen feet, and ankles. So this patient was experiencing symptoms of failure on both sides. Many times, the heart is one big muscle. So if you have a failing right side, eventually that's going to overwork the left side and the left side will fail, and vice versa. So many times people start off with either just pulmonary congestion or just symptoms of peripheral congestion, but then eventually it ends up affecting the entire body, because if one side doesn't work, eventually the other side will be overworked and also start to decline or fail. Okay, does that make sense to everyone? Okay. So now we're getting to blood vessels. You've already got a taste of it last week, learning all the arteries. This is your case study for today, so if you need to take a picture, go ahead. But James is an 85-year-old male who presents to the ER complaining of a strange and pulsating sensation in the middle of the abdomen near the belly button. He states that it has been occurring for the past 3 days, as well as deep pain in his lower back. Oscillation of the abdomen revealed a significant bruit over the aorta, and palpitation revealed some tenderness and a pulsatile mass. So what is your diagnosis? And we'll talk about that diagnosis today. Did everyone get a picture? Okay. So today's lecture objectives include talking about the 3 layers of the blood vessel and the function of each. We'll talk about vasoconstriction and vasodilation, which you should already be familiar with. We'll talk about the 3 types of arteries, and we'll compare and contrast their structure and function. We'll talk about the structure and function of a capillary bed. We'll talk about the functional anatomy of 3 types of capillaries. We'll talk about veins and how veins differ from arteries. We'll talk about anastomoses, which is something, again, we've already talked about this semester. And then you're going to have a PLA on the relationship between vessel resistance, blood flow, and blood pressure. So a cardiovascular system overview, we have what's called a closed circulatory system, where all of our blood is enclosed in these 2 systems, the systemic circulation and the pulmonary circulation. And so they go back and forth between these 2 systems in sort of a figure 8, but the blood never leaves these 2 systems unless there's an injury and you have bleeding, but it's a closed circulatory system. It's meant to be. There are many animals that don't have a closed circulatory system, who have what's called an open circulatory system. So like crustaceans and crabs, what they do is their heart actually pumps out blood to their interstitial fluid. So all of the fluid that's surrounding their organs, the blood, their version of blood, surrounds all their organs. You have diffusion of oxygen and nutrients and wastes, and then all of that actually gets sucked back into the heart. So it's a much different system than what we experience. So here's an overview of the vessels leading to and from the heart. I'm going to actually give you something a little bit more simple than that. It looks a little bit complicated when you look at it with the pictures, but this is the overall, or this is going to be your pathway that you're going to have to know. So from the heart, we go to what are called elastic arteries. From elastic arteries, that leads to muscular arteries. From muscular arteries, that leads to smaller arteries called arterioles. From arterioles, that's going to go to capillaries. From capillaries, we go to small veins called venules. From venules, we go to small veins, and then to large veins. And that brings us back to the heart. And we're going to describe the difference between all these different arteries, the capillaries, and the different types of veins in this order. So I'll give you time to write that out. Okay, everyone have this written down? Okay. So we're going to talk about first the layers of our vessels, both arteries and veins. Before we get to that, though, does anybody remember what the inside of a vessel or the inside of an open organ is called? Starts with an L. Lumen. It is the lumen. And so we're going to talk about all of the layers leading from the innermost layer closest to the lumen and then working our way out. So we'll go intima first. So the first one is the tunica intima. It does have, so tunica just means tunic or layer. Intima meaning it's like related to intimate, but it's the innermost layer, the one that's actually going to be touching the blood that's flowing through these vessels. So the tunica intima has three different sublayers. We have the endothelium, the subendothelial layer, and then the internal elastic membrane. As far as the endothelium goes, this is made up of simple squamous epithelium. So you'll hear endothelium throughout the semester. Endothelium is the innermost layer of vessels, and you'll hear that with lymphatic vessels too, as well as some organs. And endothelium is always going to be that simple squamous epithelium. Functions of the tunica intima in general include that it's a barrier. Especially for white blood cells, so into the barrier between the inside of the blood flow to the tissues. We also use it for immune recruitment. So when there is an infection or damage, this endothelial layer can actually send out messages to get white blood cells to know this is an area of interest. You need to come here and fight off whatever infection or damage that has occurred. Hemostasis. So we already talked about what happens when a vessel is injured with blood clotting or coagulation. So the endothelium senses the injury and sends a message to the smooth muscle layer to tell it to contract so that we stop blood loss for a certain amount of time. Does anybody remember what kind of signaling that would be from the endothelium to the smooth muscle layer to get it to contract? What is it? Paracrine, it'd be paracrine signaling. You have one set of cells, the endothelial cells, telling the smooth muscle cells next to it, its neighbor, to contract. Another function is also filtration. Once we get to the capillary level, capillaries are basically just going to be all endothelium, nothing else. Capillaries are very thin, do not have all of these layers that we're going to describe right now. And so that endothelial layer acts as a filter between the intravascular environment and the extravascular, or the interstitial space. Okay, any questions about that? The endothelium. The subendothelial layer is essentially just a basement membrane. If you guys remember from B32, epithelial tissue always has a basement membrane where it is going to be like the transition point between epithelial tissue and connective tissue. So the subendothelial layer is the basement membrane. With loose connective tissue. And then the interelastic membrane, now that's not going to be the elastic that's pushing blood forward. That's actually going to be the next layer. But there's just a very small layer of elastic tissue that's going to help with stretchiness. But it's not the main elasticity player here in these layers. So any questions about the endothelial layer or the tunica intima? Yes, ma'am. Yeah, so it's a barrier for the white blood cells, between where the white blood cells are flowing in the blood to the tissues where some of them will be able to escape. Yeah. All right, the next layer is the tunica media. It is made up of smooth muscle and elastic fibers. These are going to be the real players in helping us propel blood forward, and we'll talk about that when we get to these specific vessels. The tunica media, though, it is the main muscular layer, and it is controlled by the sympathetic nervous system. So you learned in B32 that our vessels have sympathetic tone. And so our sympathetic nervous system helps keep that tone in order to keep blood pressure at the level it should be. So there's always going to be some form of contraction in those vessels at any one time so that we maintain that sympathetic tone. So the sympathetic nervous system is going to be in charge of the vasoconstriction and vasodilation that occurs. One thing I forgot to mention that's in your lecture notes, it talks about intima damage. So going back to that first innermost layer, the tunica intima, there is such thing called intima damage. And this is a chronic inflammatory disease. So I'll make some notes. Well, you already have them in your lecture notes, but intima damage. This is a chronic inflammatory disease. The rest of this should be in your lecture notes. But if you have chronic inflammation throughout the body, it's also going to affect your tunica intima, the inner layer of your blood vessels. And so what ends up happening is that because of the inflammation, you're going to have lots of chemical release. And if you didn't have inflammation, that chemical release can actually lead to plaque buildup and blood clotting more than what you would want to experience. And so it can end up causing atherosclerosis over time because of all the inflammation that's occurring inside of those vessels. The risk of having intima damage is going to be things like obesity, diabetes, where you have lots of sugar flowing through your vessels causing damage. If you are a smoker, if you are over the age of 60, as your tissues begin to age, you'll experience more of this intima damage possibly. And then also if you have a high fat diet. So if you already have plaque growing in your vessels, that's going to cause chemical release from the damage it's causing inside of your vessels, which can actually lead to more plaque buildup, more blood clotting that you don't want. And so this is, again, a chronic disorder that can occur. The last layer is going to be the tunica externa. Everyone okay with me erasing the notes on the left about the endothelium? Okay, so the last layer is the tunica externa. And the tunica externa, and it's already in your lecture notes, it provides support. And it has this layer here called the vasa vasorum. The vasa vasorum is a network of capillaries that are going to supply nutrients. And this might be in your lecture notes already, so don't feel like you have to write it down again. But it supplies nutrients to cells within, WI for within the layers. So do you remember how we talked about blood flow through the heart? And so the blood that flows through the heart doesn't actually feed the heart itself. So it has to rely on the coronary circulation to feed it from the outside. This is the same concept. The blood that's flowing through the arteries and veins don't actually feed the vessels themselves because that's being directed to other parts of the body. So your vessels have this extra layer on the very outside called the vasovasorum that has capillaries to feed the vessels itself. So it has a different source of nutrients. It's not using the blood that's actually flowing through the vessels. Does that make sense to everyone? Okay. All right. Any questions about the layers? Intima is the innermost layer, then the media, then externa. So if I were to ask you to name the layers from deep to superficial, you would go intima, then media, then externa. Okay. If it's superficial or deep, it's going to be the opposite.
So for inflammation, there would be a lot of basophil cells present, more than usual?
Possibly basophils are mostly for allergic reactions. But they could be involved in the inflammatory response as well, but I wouldn't say that they would be the main cells.
So it's different than allergic reaction than chronic inflammation?
Yes, it's going to be different, yeah.
So can you use like antihistamine to reduce it?
Antihistamines are there to reduce histamine, which is specific to the allergic response. What you would use for inflammation, the corticosteroids, for the most part, are used for inflammation. All right, so elastic arteries are going to be the first. We talked about that pathway. So the heart leads or takes blood to the elastic arteries first, and we'll talk about muscular and then arterials. But the elastic arteries, elastic refers to, and actually before we get there, they actually have a different name as well. These elastic arteries are also referred to as conducting arteries. And so don't ask me why they give two different names for the same thing. Or actually, you can't ask me why. I'm going to tell you why. But elastic refers to its structure. It's made from mostly elastic tissue. So this vessel is the most elastic. And why we call it conducting is because conducting refers to its function. So why it's called conducting is during systole, your ventricles are contracting to eject blood. Okay, these elastic arteries are the ones that are going to receive it first, like the aorta is an elastic artery. So, and it's made up of mostly elastic tissue. So when the ventricles contract and eject that blood, the elastic arteries are stretched. Okay, and then when we go through diastole, they are going to recoil and come back to the same structure they were before. And so what that does, it actually pushes blood forward. Okay, so it's going to expand as the ventricles contract and then come back together as the ventricles relax. That's going to keep blood moving forward. It's conducting the pressure from the ventricles through those arteries to get blood to move forward. That's why they're called conducting arteries. So these vessels are also known as, these vessels are also known as pressure reservoirs. Okay, so I'm going to write all this down so in case, or actually it's already in your notes. So in your notes, it says it stretches during systole and then shrinks to supply blood under pressure during diastole. So it's always under constant pressure. Systole pushes the blood out. That's a high pressure. When it stretches, now it's holding on to the pressure from those ventricles. As it recoils, it uses that pressure to push the blood forward. So these, I'll keep it. So these vessels don't contract much because they're made up of mostly elastic tissue and not smooth muscle. And they are called a pressure reservoir. The reason why it's a pressure reservoir, and this also may be in your notes already, but it stores pressure from systole and uses it to move blood forward. Does that make sense to everyone why it's called a pressure reservoir? Yes.
To move it forward during diastole?
Oh, just always. So during systole, the ventricles contract to place that blood into the elastic arteries. They're going to stretch from that high pressure, that 120 millimeters of mercury of pressure. They're going to stretch, which allows them to hold on to that pressure. And so when the ventricles relax and they're allowed to recoil and go back to their original size, it keeps blood moving forward. And also that elasticity and that recoiling is so very smooth. You do not feel that at all. Can you imagine every time your heart contracted, you felt it ejecting blood? That would not feel good, right? And so these vessels stretch and then go back, and it's a very smooth movement, so you do not feel that blood moving forward. Now, if you have atherosclerosis and your arteries are hardened, you will feel those movements a little bit more than somebody who doesn't. But somebody with healthy, very elastic, strong arteries, that flow is just so continuous that you do not feel the movement of that blood as the heart pumps. Any other questions? Okay. So we'll talk about what happens when vessels do get hardened. So here is a normal artery, okay, nice and round and open. And then here's an artery partially blocked because of plaque. That plaque is going to cause those vessels to harden, and they're not going to be as elastic, and they're not going to be able to stretch and recoil as smoothly as you would see with someone that doesn't have plaque. So this plaque buildup, this atherosclerosis, this leads to loss of elasticity and loss of continuous flow. So if you were to think, if you had I don't know, I'm trying to think. If you had an old water hose that has grown hard over time, which it can with sun damage and such, every time you were to adjust that water, it would sputter out, which is not what you want with the heart. Okay, so hardening of arteries does not allow for that continuous flow. It's going to be a lot rougher as the heart contracts and relaxes. Okay. We need that elasticity. We need that continuous flow to allow for a smooth blood flow. So what happens with these is that over time, hardened arteries require a higher blood pressure to push blood through, which will eventually cause the heart to work harder than it needs to. You guys remember from heart 2, what is the name of that pressure that the ventricles must overcome in order to eject blood? What is that called? What is it called? Corbin, you know? Afterload. Okay, so having hardened arteries like this is going to cause a higher afterload, a higher pressure, which is going to cause the ventricles to have to exceed that pressure in order to get blood to continue to move forward. Go back. These are old notes from last semester. Okay, so I guess I'll just leave it here and I can just explain it to you. So the next thing is an aneurysm. So an aneurysm is when your vessels have succumbed to so much pressure that they actually end up ballooning out. So you can see on the right where you have this ballooning out. It's because they no longer have that elasticity and the walls just gave to that pressure and they weren't allowed to keep their original size. That is an aneurysm. And so this is a weakened artery over time will give to that pressure and cause this ballooning here. What you're seeing here is an abdominal aortic aneurysm, or a AAA. This is the most common portion of the aorta to experience an aneurysm is there in the abdomen. Symptoms inside of that include abdominal pain, back pain, a pulsating mass near the belly button, okay, because it is in the abdomen, and then a bruit. What a bruit is that your doctor can hear with the stethoscope for changes in blood flow. So if you have a continuous blood flow, there really isn't anything to hear, right? It's going at the same pace at all times, so there's no difference in sound that should be detected, okay, when listening for the abdominal aorta. But if you have an aneurysm, and I'll erase this so I can kind of show you what that means, is that when you have this ballooning with an aneurysm, blood flow is going to change. Oh, that's not going to erase. I'll just keep it. I'll do it in a different color. So what's going to happen, instead of the blood moving forward at a continuous rate with no detectable change in sound, when you have an aneurysm, once the blood gets to where it balloons, now that blood is finding all the space to be able to move around. You are going to be able to hear that with a stethoscope because now you have an interruption of blood flow. Blood is hitting up against the walls as it has all this extra room to move around, and that is a bruit. So that is what a doctor will be listening for, is that disruption of blood flow, that change in blood flow, that more chaotic blood flow as it's trying to make its way down to those arteries at the bottom. What are these arteries at the bottom called? Common iliac arteries. So as the blood is trying to make its way to those common iliac arteries and it suddenly finds itself with more room to move around, it will move around. And it will hit up against those walls, making a bruit sound is what it's called. So an abdominal aortic aneurysm is caused by an increase in blood pressure. Okay, so that over time, if your vessels experience a higher blood pressure, it's going to cause them to weaken over time and eventually can balloon. It could also be caused by a vessel disease. If you have a genetic vessel disorder, it can also lead to aneurysms. If you have atherosclerosis, where you have plaque forming in those vessels, which is going to weaken those vessels over time as well and harden them, or also trauma. All of those things can lead to abdominal aortic aneurysm. And I'll move my head out of the way, Blanca. Any questions about an abdominal aortic aneurysm?
So this can happen like from one of them from having atherosclerosis and increasing blood pressure that happens.
Mm-hmm. So as your, go ahead.
Increase in systolic volume.
That would increase in systolic volume, yes. If you have a higher afterload and you're having to reach a higher pressure than you were before, that gives you less time to eject and you'll have less blood left over. Great connection. Yes.
Can't that be reversed?
Oh, no. Once your vessels give, then they're not going to go back. No. It's almost like once you gain a significant amount of weight and then you lose it, then nothing ever goes back in the same form that it was before. If anything, you would need a graft or something if you really wanted it to go back. But that's not usually what's going to happen in the abdominal aorta. It's too significant of a vessel to undergo a surgery like that. And these are usually slow growing, so they'll start off small and then balloon out more and more. as the damage increases. Okay. Anybody still need time to write the stuff down? Any questions on an aneurysm? Okay. So remember, an aneurysm is anytime a weakened artery balloons like this, but you'll only see things like a bruit or a pulsating mass in the abdomen if it's an abdominal aortic aneurysm. But this can happen anywhere. All right, so muscular arteries, it saves me time because all these notes are still there. For the muscular arteries, next arteries in line, so after elastic arteries, we move to muscular arteries. The other name for these are distributing arteries. So muscular arteries has to do with its structure. It's made up of mostly smooth muscle. And the distributing arteries has to do with its function. Distributing arteries are the ones that are going to distribute this blood out to all the individual organs. So all the vessels that you learned, most of them are distributing arteries, like your renal arteries, your gonadal arteries, your common hepatic, your splenic. Those are all distributing or muscular arteries. They deliver blood to the specific organs. There is more smooth muscle than elastic tissue. So with these ones, you have more vasoconstriction happening to move blood forward, and they don't have as much give as the elastic. So the elastic arteries, they rely on the pressure from the heart to cause that expanding to allow them to push blood forward when they recoil. Once we get farther away from the heart and we get to the muscular, you're not going to have as high of a pressure because now you're farther away from your source of contraction and your source of pressure. So as we get farther away from the heart, they have less pressure. So now once we get to the muscular arteries, they have to rely on that smooth muscle to contract in order to keep that blood moving forward at the same pace. Does that make sense? Okay. So they have more vasoconstriction, they're going to contract more to keep that blood moving forward, and they don't expand and recoil as much as we see with the elastic arteries. Another way to keep that pressure high and to keep the blood moving forward, you'll notice with elastic arteries, we have a larger lumen than what we see with the muscular arteries. Really big, thick muscular layer, the lumen's smaller, that keeps the pressure high to allow that blood to keep moving forward. Am I going to test you on the exact measurements? No. Just know elastic arteries are going to be mostly elastic. They use pressure from the heart to keep blood moving forward. Muscular arteries are going to have a much thicker, smooth muscle wall, and they rely on contraction to move blood forward. So know the basic physiology. I won't be testing on the specific diameters and lengths of these vessels, so don't worry about that. All right. Any questions on this? Anybody still need these notes? So our last one are arterioles. This is where we transition from our larger vessels like your elastic and muscular to our capillaries. So the arterioles are kind of the middleman between arteries and capillaries. So this is a transition to there. Larger arterioles will have all three tunics like we saw before, the tunica intima, the media, and the externa. But smaller arterioles will only have a single layer of smooth muscle with endothelium because we're transitioning. Capillaries only have a single layer of endothelium and that's it. So we could not go straight from 3 layers to a single layer. That would not cause or would not allow for a smooth transition. So we have to kind of shave off the layers little by little as we get smaller and smaller and we lead to the capillaries. All right, so don't write this stuff on the write down just yet. We'll talk about this in a second. I'm going to write down some other things about arterioles first. Oh, let me discard this stuff. . So again, this is the transition. To our capillaries. We are going from 3 tunics down to 1. Again, larger arterioles. Have all 3 tunics. Smaller arterioles. Have a single layer of smooth muscle. Oh, what kind of tissue did I say endothelium was? What is it? Yeah, what specific type of epithelium? Simple squamous. So I said before that the elastic arteries have a larger lumen. The muscular arteries have a smaller lumen. These arterioles will have even smaller lumens. So think of the elastic arteries. Those lumens are going to be about the size of your pinky. That's going to be the opening for those elastic arteries. When we get down to the muscular arteries, that's more like the pencil lead, would be maybe that thin. Once we get down to the arterioles, this can be as thin as a single hair strand. So a very, very thin lumen as we get down to these arterioles. These are referred to as resistance vessels, which again, the second name always has to do with their function, not so much their structure. Arterioles have to do with their structure in that they are small arteries. That's why they're called arterioles. And so resistance vessels, their flow is determined by their diameter. And with these vessels, the smaller the diameter, the higher resistance to blood flow. So R is for resistance. D is for diameter. So when thinking about resistance to blood flow, higher resistance means that it makes blood harder to flow through those vessels. So think about like a straw. Is it easier to drink, let's say a smoothie, out of you ever seen those little coffee stirrer straws, the really thin ones? Would it be easier to drink a smoothie out of that or out of a boba straw? A boba straw, right? A boba straw has a higher diameter and therefore a lower resistance to flow. It's much easier for blood to flow or any liquid to flow when you have a larger diameter. Does that make sense to everyone? Okay. If we were to make that diameter smaller, if you try to drink a smoothie out of a coffee straw, that would not be easy at all. You probably get a headache from trying to suck through that teeny tiny straw. So what this allows for, and it'll make more sense when we get to capillaries here in a second, this relationship allows blood flow to bypass tissues when necessary. So I'm sure you learned in B32, when your sympathetic nervous system is activated, blood is directed towards your heart and your brain, your skeletal muscles, and everywhere else is kind of bypassed, right? During that time, during sympathetic activation. How we make that happen, these arterioles make their diameter really, really small, so blood doesn't want to flow through those areas. And so those areas get bypassed. That way the blood can be redirected to the areas that need it. Okay.
Bypass the tissues of it just like diffuses out.
It just bypasses it. So I'll show you. very simple. Do not tell people that I told you that this is what the body looks like. Okay, so let's say this is a capillary bed that's going to the kidneys. And this is a capillary bed that's supplying. Oh, damn it. It went away. I'm going to do it on the board. Sorry, those of you rewatching, I'm writing something on the board. So just forward for the next 5 minutes. Do I have a balloon? Yes, okay. Okay, so let's say this was, do a different example. Say this is a capillary bed going to the brain, and this is a capillary bed going to the stomach. Obviously, they wouldn't be this close to each other, but let's say you're in sympathetic activation, you are in fight or flight mode. What's going to happen is that the arterioles going to the brain are going to dilate to allow blood flow to go into that capillary bed and feed the brain. And what we mean by bypass is that organs like your stomach, those arterioles will constrict and make it so small that the blood is literally going to bypass and just go past that area. It's as if the stomach put up a do not disturb sign, and so the cleaning lady just went past that door. Yeah.
Are the capillaries that like say the brain and the heart, are they larger than other capillaries? Or
They may have more capillary beds in the areas that need more blood flow. Any
You're
question?
saying that it's like bypass to go to the brain?
Yeah, so if all the different, because it's a figure eight, it's going to go through the same pathways all the time. So if all of the arterioles that are leading to like your stomach and your intestines and your liver and your kidneys, if all of those are dilated as it's going through this figure eight, and these ones are all, constricted, and these are all dilated, all that blood's going to go to those areas as it keeps bypassing those other organs that don't need the blood at that time. Does that make more sense? Okay. Any other questions on that? Okay. All right. So this occurs, this dilating of vessels at these capillary beds. This occurs via neural controls, so fight or flight mode, hormonal controls, and also other chemical control. I'll say cues. So cues are triggers. This occurs by neural cues, hormonal cues, or chemical cues. So either a neurotransmitter or a hormone or some other chemical messenger will cause those arterioles to dilate. What's really cool is that when you get a facial surgery, the doctors will actually inject epinephrine into your face because that's going to cause those vessels to constrict, and blood will bypass that area. So while the surgeon is doing his procedure, you don't have as much bleeding in the face. So it allows for a cleaner, easier surgery. Mm-hmm.
Does that damage the tissue or just slows down the death?
What damages the tissue?
Making the blood vessels smaller.
No, that's temporary. So if we're using it for surgery, it's only going to stop blood flow for a short amount of time while the person conducts their surgery, and then as the epinephrine wears off, then it's going to dilate again and blood flow will resume. All right, any questions? So we went through elastic arteries, muscular arteries, arterioles. Now we're getting to capillaries now. So this is what I was trying to draw. Where did my purple pen go? Oh, there it is. Okay. This is what I was attempting to draw. So it's these arteries right here at the end that'll either get bigger or smaller. So they'll either, they'll either dilate or constrict to either allow more or less blood flow into that capillary bed. Not the best recreating of that, but I tried my best. All right, so capillaries. Capillaries are the smallest of our blood vessels. They are microscopic connections between the arteries and veins. The diameter is only slightly larger than an erythrocyte, which is really important because this allows, if you look over here to this vessel here, because the capillaries are only slightly larger than an erythrocyte, it allows the erythrocytes to go through in a single file line. So this allows us to deliver all the oxygen nutrients as much as we can as possible to the organs, and allows us to pick up as much waste as we possibly can on the other side. It would be much harder for diffusion to happen across these erythrocytes and across the capillaries if they're all bunched up in a group together. So as they go in a single file line, it allows for much more efficient diffusion of oxygen, nutrients, and also waste products. Does that make sense? Okay, so allowing them to go in a single file line just increases the efficiency of diffusion. For most of capillaries, their wall consists of just a tunica intima, so a single layer of endothelial cells, which allows, again, for that rapid diffusion. If we had all three layers, the intima and the media and the externa, diffusion would not happen as quickly as we need it to. So at the capillaries, it needs to be a single set, a single layer of simple squamous epithelium to allow for that rapid diffusion. Okay? Many more layers and we wouldn't get oxygenated enough. And this is an actual micrograph of a vessel, and you can see it actually is just slightly larger than an erythrocyte, and these vessels are moving in a single file line. All right, so we have three different types of capillaries found in different places in the body. The first type is a continuous capillary. These are the least permeable and the most common. What we mean by least permeable, it allows for the least amount of materials to get through because it only has what are called these intercellular clefts. So these capillaries, yes, they're a single layer of epithelial cells. So here's like one cell. It would have a nucleus. Here's another cell with a nucleus. Here's another probably cell over here with a nucleus. So these vessel walls are made up of a single layer of these epithelial cells all together. And so the only spaces for things to diffuse over are in these intercellular clefts. So in between the spaces, in between the cells, then things can diffuse in and out. So they're abundant in our skin, in our muscles, in our lungs, and also our central nervous system, where we don't want a whole lot of things being lost in the cracks. Yeah?
So the single layered epithelium, that's still made up of the three layers?
No. So once we get down to the capillaries, we do not have the three layers anymore. There's no more externa. There's no more media. It's just the intima. So if you go back, it is, for most, their wall consists solely of a tunica intima. That's it. We've now transitioned from three layers to only a single layer, and that tunica intima really is just a single layer of endothelial cells. We don't even see the internal elastic membrane and all of that. It's going to be a single layer of epithelial cells of simple squamous that allows for the rapid diffusion. So again, we're going to see these continuous capillaries that are not so permeable in places like your skin, where you don't want to lose a whole lot of water, also muscles, where you also don't want to lose water or lose calcium, things like that. In your lungs, also where you would not want to lose water. And then your central nervous system. If you remember, your brain is very sensitive to changes, especially in things like proteins and other chemicals, ions. And so we want to keep that connection really tight. And so in these continuous capillaries, you'll see a lot of tight junctions. And then, do you guys remember the name of the structure that provides an extra layer of filtration for the central nervous system to allow even less things to go between the blood and the central nervous system? I said part of the word just now. Blood. What is it?
Blood-brain barrier.
The blood-brain barrier. So your central nervous system has this blood-brain barrier that allows, or it puts up an extra wall between the blood and the brain so that it doesn't experience those changes. Does anybody remember the cells or the neuroglia of the central nervous system that make that blood-brain barrier? Start with an A. Astrocytes. All right. Any questions? Huh?
I didn't want to say it, I thought I was wrong, but I can't believe I remember.
Yeah, astrocytes. I'm telling you, literally everything connects. Like all these things all connect to each other. And so, it literally was right there, blood-brain barrier. So B32 review, blood-brain barrier, brain capillary endothelial cells lack these intercellular clefts and have tight junctions around the entire perimeter, plus the astrocytes to really make sure that there are no new chemicals coming into and out of the brain. So those are continuous capillaries. Next are fenestrated capillaries. Fenestrated capillaries have large fenestrations or pores that increase their permeability. So these have little pores throughout. And these, you're going to find these in places that do a lot of filtration. So you have them in the kidneys where we're filtering out blood to make urine, or where we have a lot of absorption like the intestines where we need to be able to absorb the nutrients and the monomers from the food that we eat. And also for areas of hormone secretion. So when we need to let hormones out throughout the body, we have fenestrated capillaries in those areas in order to allow for the cells of the endocrine glands to be able to then release those hormones into the bloodstream. So fenestrations are Swiss cheese-like holes that tunnel through the endothelial cells. What's really cool about our digestive system is that in active times of absorption, so once you've eaten a big meal, you've broken it all down, your intestines can actually increase the number of pores during that time so that we absorb even more nutrients. And then they'll go back and fill in those holes, which is really cool. I think it's really cool. Biggest thing about these vessels is knowing the names of these vessels, how permeable they are, and where we're going to find them. So continuous capillaries are the most common. They are the least permeable, and we find them in the skin, lungs, muscles, and central nervous system. The fenestrated capillaries, they're going to be somewhat permeable, not the most permeable, but they'll be somewhat permeable. And we're going to find them in places where we filtrate, at the kidneys, where we absorb, at the intestines, and where we release hormones at the endocrine glands. The ones that are the most permeable are what we call sinusoid capillaries. Sinusoid capillaries are the most permeable, and we only find it in some locations. We'll find them in the liver, bone marrow, spleen, and the adrenal medulla. So the liver and bone marrow, specifically the bone marrow makes whole cells. And you need to be able to put those whole cells into the bloodstream. So we'll find these sinusoid capillaries in the bone marrow so that when the bone marrow makes those cells, it's easy to release them into the bloodstream. Also, your liver makes blood proteins. Name me some blood proteins we talked about. You have an exam on it in a week. Albumin's one for osmotic gradient. What else? Fibrinogen is another one. What's the last one? Globulins, like immunoglobulins. Yes, please remember those. So we have these big blood proteins that come from the liver, and they have to be able to, the liver cells have to be able to release those into the bloodstream. So we need these capillaries with large gaping holes in order to be able to release those big proteins into the blood. Your spleen captures old red blood cells and recycles them, so we need to have those sinusoid capillaries there as well. And the liver and the spleen are also take over red blood cell production or blood cell production when we are infants and when we are small children. And so we need those big capillaries, sinusoid capillaries in those areas. Adrenal medulla. What hormones get made at the adrenal medulla? The norepinephrine, epinephrine, which we call what? Catecholamine. So also there, we need to be able to release large amounts of those hormones there at the adrenal medulla. So they will have large intercellular clefts. So you'll notice these spaces in between the cells are much larger with sinusoid capillaries. They won't even have a complete basement membrane, so there are pieces of the basement membrane just missing that allows more flow into the bloodstream, as well as these large pores, huge pores. It allows large molecules and cells to pass through. And then what's also very cool, which I don't think I have a picture of, I'll have to show you when we get to the immune system, but our macrophages, monocytes, they can actually extend their cytoplasm out of these sinusoid capillaries, capture some bacteria, and then bring it back into the bloodstream, which is really cool. They don't have hands or fingers, but they can extend their cytoplasm, pick stuff up, and bring it in. So any questions about the three types of capillaries: continuous, fenestrated, and sinusoid? So again, know their permeability. Continuous is going to be the least permeable, sinusoid the most permeable. Know overall what they look like, as well as their locations. So capillary beds, we already talked about this a little bit. So capillary beds, how we kind of control flow through these capillary beds during times of sympathetic activation and parasympathetic activation is that these arterioles will constrict. So when arterioles are dilated, it allows for that blood to enter the entire capillary bed and fill it up and provide that organ with oxygen and nutrients, and then pick up their waste products on the other end, and then the blood flows back to the vena cava and back to the heart. When the arterioles are constricted, though, and they're smaller, this allows blood to bypass those areas. So again, like your digestive organs when you're in sympathetic activation. So that blood is bypassed, so you can see that the blood does not end up filling up that capillary bed. It moves on to the next organ. So this is a typical capillary bed. Where blood flow is controlled by the arterioles. Another type of capillary bed is one that is controlled by what are called precapillary sphincters. This is not a typical capillary bed. This is found in the mesenteries, which are your intestines, and brain. There was a study done on it in 2020. So this is very kind of new information. But there are some areas, again, like your intestines and your brain, where it's actually controlled by sphincters. And so a sphincter is a circular piece of muscle that can contract to stop flow of a type of fluid from one area to another. We have sphincters in our digestive tract as well that makes sure that your food stuff stays in your stomach when it needs to stay in your stomach, and they only open when you need to move it to the next spot, which is your small intestine. So we have sphincters all throughout the body. So these capillaries with precapillary sphincters, what they will do is those sphincters will constrict in order for blood to not completely bypass, but it will allow some blood flow through without filling up the entire capillary bed. So it's thought that areas like your brain and your intestines need constant blood flow, but there are times where you want less or more blood flow. So this allows for blood to still fill up that capillary bed, but maybe not entirely when we don't need it to fill up entirely. Does that make sense? All right. Now this happens, so again, during sympathetic control, organs will be bypassed like we saw here during times of fight or flight. So it's really important that you don't have sympathetic activation on for a very, very long time, because then you're bypassing important organs for a long period of time. So one thing that's going to get brought up a couple of times this semester is that you should never run a marathon or a triathlon or some really long-term sporting event without training for it. If somebody were to just get up one day and say, hey, I'm going to decide to run a marathon without having trained for it, well, now you're going 12, 20 hours without proper blood flow to your kidneys, and you can actually go into kidney failure from doing that type of extensive activity without training. So you have to give your body time to adapt. People who train for marathons train for months in order to get that endurance, get that stamina up, and also to allow their bodies to adapt to that low blood flow for that period of time. Okay, so always train before you do any kind of really extensive sporting event. All right. So we went over arteries, we went over capillaries. Now we're going to get into veins. Is everyone okay with me? We'll just keep moving until we get to the end, and I'll give you 10 minutes when we're done. Unless anybody really needs to stop now, we'll stop now. We're going to keep going. Everybody good? Okay. So veins are a little bit more simple than the arteries. Okay. Veins in general, what you're looking at right now is the venule. That's right after the capillaries. These have very thin walls. And I'll move on to show you the veins as well. They have very thin walls, especially the tunica media. So once we're done with capillaries, when we go from venules to veins, now we're building back up those 3 layers. We're going to go back to having 3 layers again. And so the veins are going to have very thin walls, especially the tunica media. What is the main tissue type in the tunica media? Tunica media, the middle portion. What's the main tissue type there? Smooth muscle is the main tissue type there. Now, the tunica media of our veins is very thin because their job is to collect, not distribute. So our muscular arteries, they need that smooth muscle to push blood forward in order to get that blood delivered to the organs that it needs to. The veins, they're not directing blood anywhere. They're just collecting it and putting it back to the superior vena cava, which is going to go back to the heart. So they're not really giving blood anywhere. They're just returning it back to the heart. So make sure you also write down that these smaller venules will transition into veins. And then compared to our arteries, these veins will have larger lumens. Why veins have larger lumen than arteries is that this allows veins to move the same amount of blood as arteries. At a lower pressure. So like I mentioned, the farther and farther we get from the heart, the lower the pressure in these vessels are going to be. So how do we get the veins to keep moving the same amount of blood as the arteries are, even though they are a much lower pressure, less smooth muscle for contraction? And so how we do that is by creating larger lumens. Okay, so they can hold more blood than an artery can. This is like, think of arteries being like a 2-lane highway going 90 miles per hour versus our veins are like a 10-lane highway at 20 miles per hour. Nobody do the math. I'm not a mathematician. This does not equate in that way, but you get the idea. Okay, in arteries, we're moving the same amount of blood, but much faster. With veins, we open up those lumens so we can move the same amount of blood at a slower rate. Okay. Does that make sense to everyone? Okay. Any questions on that? So because these veins have a larger lumen, they actually hold 60% of our blood at any one time. So because of those larger lumens, they hold 60% of our blood. So these are actually called our systemic veins and venules are our blood reservoirs. Because at any point in time, your veins are going to be holding most of your blood.
So are the capillaries what receive like the oxygen?
Yeah, so at the capillary bed, they're delivering the oxygen to the organs and picking up their waste products. That is the only place that can happen. Anywhere else, the walls are much too thick to allow any kind of diffusion to occur. Yes?
So capillary beds, they're under low pressure.
They are typically low pressure.
So where do veins get the, I'm just confused on where they get the power for venous return to get back up?
We're going to talk about that here in a second. All right, so one way that we get that blood to keep moving forward, even though it's a very, very low pressure system in our veins, one way is, what is the main job of a valve? To prevent backflow. And for veins, it's to prevent backflow in a very low pressure system. So, and I'm going to show you this as well. So how we get the blood to move forward, even though there's not much smooth muscle, there's not much pressure moving it forward, is, we talked a little bit about how we increase EDV through skeletal muscles. It's the same thing. So as we are moving, we're walking, our skeletal muscle is pushing up against our veins and contracting against our veins to push blood forward. And then because we have such a low pressure system, and because if I'm standing up and walking, gravity is going to try to pull that blood down, my arms and my legs, the skeletal muscle moves that blood a little bit forward, and then the valve catches it. And then moves up a little bit more forward, and the valve catches it. And it goes all the way up until you get to your abdomen. And then once you're in your abdominal pelvic, your whole ventral body cavity, what ends up happening is your lungs are opening and closing, and what that does, it causes a change in pressure inside of your ventral cavity. And so what ends up happening is, as the blood gets into your abdomen, into that space, that change in pressure actually sucks the blood into the heart. So you actually don't even have any valves in this area, because the blood will move off of that change in pressure, sort of creating a little vacuum that sucks it into the heart. So these valves here that we find in the veins, they resemble semilunar valves. You can see they have that kind of semilunar shape. They are found in most veins, especially in the limbs where gravity is working against blood flow. But they are not found in the abdominal and thoracic cavities.
Do we have them in like the brain?
For veins, yeah, anywhere that's not, yeah, you'll have them there as well. So people who are bedridden will not have that same kind of movement forward, which is why you may see people who are bedridden, especially in a hospital, they'll put blood pressure cuffs on their extremities to help move that blood forward, to make sure they're getting adequate delivery to their hearts. All right. What is it called if a blood clot gets stuck to the side of a vessel? Thrombus. And if a piece of that thrombus falls off and flows through the blood, what's that called? Embolus. Okay, just making sure. All right, because next we're going to talk about varicose veins. So varicose veins are caused by, and I'm going to write some notes first. Varicose veins are caused by incompetent valves. So valves that are no longer working. And varicose veins are common for people that, and I'm writing a list of things. Who are 1, obese and overweight. Or pregnant. And also those that stand for long periods. So people like nurses and healthcare professionals and postal workers and teachers and things like that stand for long periods. Why varicose veins are more common in those kinds of people is because you have a pooling of blood in the legs and feet. Now that seems pretty obvious for people who are standing for long periods of time. If you're somebody who's standing a lot in your job, gravity is going to work against blood flow and you'll get a lot of pooling of blood in your legs and your feet, where blood just kind of stays there for longer because you're on your feet for so long. Also for people who are overweight or obese, especially men who have like pot bellies that kind of stick out, there's a lot of downward pressure that's also working against gravity. So if you are overweight or you are pregnant, again, with a big, large belly that's working against blood flow, then you'll have pooling in your legs and feet as well. And so what ends up happening for people who have that pooling that's occurring, those valves are overworked because there's just a lot of downward pressure on them, which leads to these valves failing, and then they become weak and twisted. And then because of that, swelling occurs. In previous section of vein. It's previous section of the vein.
That's why people really like compression socks.
Yes, that's exactly why nurses and other people who stand for long periods wear compression socks. It keeps that pressure on their legs and their feet to allow that blood to keep moving forward. Yes. It's very important as a nurse to wear compression socks. Okay, any questions about that?
Can varicose veins lead to more serious issues, or
Well,
are they just aesthetic?
No, they can lead to more serious issues, because if you have someone who has that pooling of blood that occurs, and with varicose veins, they'll get even more pooling of blood with these valves that failed, you have an increased risk of a clot forming, an increased risk of that clot sticking to a vessel wall, causing a thrombus, and then an increased risk of a piece falling off, leading to the lungs and causing a pulmonary embolism. So that risk is also there with varicose veins. So I guess we can write that down too. Everybody have these notes up on or written down? Okay. So with varicose veins, you have a higher risk of thrombus forming, which can eventually become an embolus, which can travel to larger veins, which then go through the heart, and then eventually get stuck at the capillaries of the lungs. And again, what's that called? Pulmonary embolism. So you can see how these veins before, just a continuous forward blood flow, the valves are fine. But once you have lots of pooling and lots of downward pressure and the valves fail, you have lots of backflow, which is going to cause the veins to become weak and twisted, which then show up on the surface of the skin.
So if you have a blood clot in the veins, is it always gonna go to the lungs? Will it always be like a pulmonary embolism?
If it's in your legs, yeah, and it gets that far, yeah. Because it'll go from your legs up to the larger veins of your abdomen, eventually to your vena cava, to your heart, and then where it gets stuck is in the lungs. Yes.
The capillaries are in lungs are the capillaries same size as in legs and lungs?
All capillary beds are about the same size. Again, some larger organs will have more capillary beds than smaller organs, but they're going to all be pretty much the same size. You can get surgery to correct the varicose veins. There's microsurgeries you can do to kind of fix that. But if lifestyle changes don't occur, they're gonna keep reoccurring. All right. One other case of varicose veins. So whenever you have high venous pressure, this can lead to varicose veins. And times that can happen are in times of childbirth and if you force bowel movement. And this will cause varicose veins in the veins of the anus. And what are those called? Hemorrhoids. Which are not fun, do not recommend. So any questions about varicose veins? Okay. All right, a specific type of vein, a large collecting vein, is the coronary sinus, or sinuses in general. So a sinus is essentially enlarged endothelium without the tunics. The job of a sinus is to collect blood and return to the right atrium. Anybody remember what the sinuses in the brain are called? The dural venous sinuses. Any questions about sinuses? Anyone still need these notes up? Okay. One of the activities you're going to do today is you're going to look underneath the microscope to be able to tell the difference between an artery and a vein. Arteries are going to be much thicker with a smaller lumen and a much higher pressure system. So you'll notice with the artery has a much thicker wall, large tunica media, lots of smooth muscle there, versus a vein that has a much thinner wall. Also, you'll notice that the lumen is filled with red blood cells, high pressure, not a lot of white space. But with the veins, that's a much lower pressure system, you see a lot of white space. Not a whole lot of blood cells. Well, still a lot of blood cells, but they just have a lot of space to move around because it's a much lower pressure system. Also, another thing you'll notice, because of the thick wall of the tunics, the artery is going to have a nice round shape. But because the walls are thinner and not as strong, the veins, actually, when you take a slice of them, they collapse a little bit and they have an irregularly shaped lumen. So here again, arteries on the left, thick, small lumen. Vein is going to be irregularly shaped, larger lumen with a lot of white space. Now these are larger arteries here, so how you could tell the difference in these ones is the shape. So nice round shape of the artery, a collapsed irregular shape of the vein. For this one, is the vein on the right or the left? On the right. Again, irregularly shaped, much more white space and thinner walls than we see on the left. So everybody be comfortable with telling the difference on a microscope image. Okay. All right, anastomoses. You already know what anastomoses are. They're reconnecting of vessels to provide an alternate route for blood. So anastomoses provide alternate pathways. And we call these collateral channels. So examples of anastomoses that you should be able to identify on the models is going to be the anterior interventricular artery, also known as the LAD. Well, not like that. And actually, I should spell it out because you're going to have to spell it out. So it can also be called the left anterior descending artery. It's also known as the anterior interventricular. Oh, it's right there. Just kidding. Anterior interventricular artery. So you can call it either one, but that is going to have an anastomosis with the posterior interventricular artery. So the front main artery on the heart is going to meet with the back, and they create an anastomosis on the bottom. The other anastomosis of the heart with coronary circulation is the circumflex artery on the back side of the heart meets up with the right coronary artery. So you can see both of those. Here's the circumflex going around the heart, and here it comes to the back to this capillary bed here. And then you can see the right coronary coming and meeting up on the other side. So if there was any kind of blockage on either side, the other vessel would be able to compensate and reach over to that blockage so that the heart maintains that continuous blood flow. So if we were to have a blockage here in the circumflex, then the right coronary would be able to come across and come to this side and feed the heart on the other side of that blockage.
So if there is a block, can your body even tell because of the, like, it will affect the heart at all because of the block? Or no?
Well, it will, but this just provides an alternate pathway to provide blood in that blockage. But you still have a space of the heart that's not receiving any blood where there's going to be that blockage there. And so it's still going to damage the heart either way, but there are ways to limit the damage through these collateral channels. Any other questions on anastomoses? We also have anastomoses in the brain. So we learned about the cerebral arterial circle or the circle of Willis. The ones that are providing the anastomoses are the communicating arteries. They're closing the loop on the bottom of the circle and then on the top part of the circle. So those are your anastomoses there being created by the communicating arteries. We also have naturally occurring anastomoses, which is really cool that our body is able to do this. If we have ischemia that's occurring in our vessels, and this happens mostly in veins, but if we have ischemia occurring where you have less blood flow because of plaque building up, your body over time can start making new connections outside where the blockage is. So that eventually, if it does close up all the way, you have these alternate routes of blood that are already created. So your vessels have the ability to sense this damage over time and this closing of this pathway, and they can start building these collateral channels and making connections. Isn't that awesome? Aren't our bodies freaking awesome? Again, you'll hear me get excited a lot on these kinds of things. Okay, last little thing. This is about your homework. So you'll be doing a PLA with respect to pressure and resistance. We talked about it a little bit already. But blood flow through the vessels, how we measure blood flow. Flow is equal to pressure, or specifically a change, and the triangle is for change. It's pressure over resistance, but you may also see it as a change in pressure over resistance. But that's our equation for measuring flow. And then now it's hard to measure flow specifically through the arteries, but what we can measure is cardiac output. What was the equation for cardiac output? Heart rate times stroke volume. So it's easier to capture cardiac output, and what is outputting or what's being forced out of the heart is going to be equivalent to what the arteries are filling, especially those very first arteries, those elastic arteries. So what we can do is we actually, at rest, can set these equal to each other. So flow of blood is equal to cardiac output at rest under normal conditions. And remember, we said if you have a decrease in diameter, that's going to increase resistance to blood flow. Like with atherosclerosis. If you start having plaque in your arteries and the diameter decreases because it's being taken up more by plaque. So if we go from here to here, where now the diameter has gotten smaller, we go from this much of a diameter to this much. You're going to have a much higher resistance to blood flow. It's going to be harder for the blood to flow through this smaller vessel now. So if we equate flow to cardiac output, what was the average cardiac output? Do you guys remember? 5 liters per minute. So if we have 5 liters per minute for cardiac output, we're going to equate that to our pressure over resistance. We have now switched out flow for cardiac output, but we can still set it equal to pressure over resistance. What is our normal systolic pressure, about average systolic pressure? 120. To make math a little bit easier on you all, we're going to say 100. 100 for systolic pressure. Over, and I'm going to tell you what the resistance factor is at rest, is 20. So at rest, if you have about 100 systolic pressure over the resistance factor of 20, that gives you 5 liters per minute. Okay, 100 over 20 is 5. Now, if you had atherosclerosis, if this over here was going on, okay, and you had atherosclerosis, and your diameter got smaller because the plaque is taking up more space, and so you have a higher resistance to blood flow. So if resistance were to increase to 40, and so we had 100 over 40, what would be our new flow then? What's 100 over 40? What? Use your calculator. What's 100 over 40? 2.5. Do you think we would survive with only 2.5 liters over a minute compared to the 5 liters per minute that we get? No. So what we would have to do in order to correct, and I'll write this in a different color so it doesn't get confusing. To correct, the body will increase pressure. So in order to maintain that 5 liters per minute, we would have to increase the pressure to 200 over 40 in order to get us back to that 5 liters per minute. And so with patients that have atherosclerosis and therefore a decreased resistance to blood flow, the heart has to compensate for that by increasing the pressure. Blood vessels have to increase their pressure. And so a patient like this would end up having chronic hypertension. Does that make sense to everyone? Okay. Any questions? Okay, I'm gonna leave this up and I'm gonna show you your homework for today. And then we'll be done. I'd rather get through as much a lecture as possible so that we don't have any lecture leaking over to next week. I want next week to just be studying for Wednesday's exam.
That all is like for the post-second, right?
Mm-hmm. Okay, questions? Oh, but if you go to the next page, there's more questions for the PLA. So that's just like the explanation of the PLA. You should go one more page and then it should be the actual PLA. Yes. So you'll notice you guys are at the end of your exam 1 lecture notes. I should have for you on Wednesday your exam 2 lecture notes. Feel free to pick them up. If you're not ready to look at it, you can wait till like Monday or Wednesday, but I'll have them in here this week for you to get your next set of notes. Okay. So that is it for today's lecture. Again, your PLA is going to be on the very next page. There's all kinds of questions on pressure and resistance and blood flow, things like that. It should be, what page is it on? 68. So on page 68, we'll have the list of questions if you go to the next page after the notes. And that will be due when I see you again on Wednesday. Anybody have any questions? Okay. Just so you guys can just have, I'll give you guys 10 minutes here in a second. But for today, you guys should be showing me your PLA number 5, which is the clinical heart terms. I'll check that after this 10-minute break. Vessel diagrams are not due until Wednesday, and your tracer drop is not due until a week from today. So you still have time on those assignments. But any questions before I let you go? Okay, go ahead, take a 10-minute break. Come back at 10:05 or 10:06 or 10:07 now. Come back at 10:07 and then we'll go over veins.